A very good morning to one all present. I am Dr. Sanjay from the Department of Oral and Maxillofacial Surgery, Sri Balaji Dental College. It gives me an immense pleasure to present in front of you on the topic titled Osteomyelitis, Osteoradionecrosis and Osteochemionecrosis. Now we look into the synopsis. Osteomyelitis, etiology, predisposing factors, pathogenesis, classification, management, which is further classified as medical management and surgical management. Then comes the osteoradionecrosis, its etiology, risk factors, pathogenesis, clinical findings, and its treatment, followed by the hyperbaric oxygen therapy. Osteochemionecrosis, followed by the bisphosphonate uses, classification, mechanism bisphosphonates, stages of bronze, prevention modalities of bronze, and its treatment. Now we go into introduction. Osteomyelitis is nothing but it is the inflammation of the medullary portion of the bone. It is confined to the endosteum and affects the cortical bone and periosteum. It is defined as an inflammation of the bone that begins as infection of the medullary cavity, which rapidly spreads to the Havacian systems and quickly extends to the periosteum area. When infection is established in calcified portion of bone, the pus in the medullary cavity and the subperiosteal compartment compromises or obstructs the blood supply. We go into the etiology. In the jaws, contagious spread of the odontogenic infection that originated from the pulpal or periapical tissue being the primary cause of the infection. Trauma, being untreated compound fractures, is the second common cause. Infection from periosteitis after gingival ulcerations, lymph nodes infected furuncles, or lacerations and hematogenous origin may also cause, being less common in jaw osteomyelitis. Now we look into the predisposing factors of osteomyelitis: diabetes mellitus, autoimmune disorders, agranulocytosis, anemia, especially sickle cell anemia, leukemia, AIDS, syphilis, and steroid drug use. Alcohol and tobacco abuse have also reported to cause osteomyelitis. Conditions which alter the vascularity predisposing to osteomyelitis, namely radiation, osteoporosis, osteopetrosis or marble bone disease, Paget's disease, fibrous dysphasia, and bone malignancy. Now, in a nutshell, I can explain the pathogenesis. The acute inflammation, which starts as an edema followed by the pus formation. Due to the presence of the pus formation, increased intramedullary pressure is seen inside the bone. Due to the increased pressure, vascular collapse, which leads to stasis or ischemia of the bone, that is, the reduced blood supply to the bone. So it becomes avascular. This pus organism gets extended and to the Havacian system or the nutrient canal involvement. This also causes the elevation of the periosteum, leads to the disruption of the blood supply, and bone gets infected and avascular. Now we look into the classification of the osteomyelitis. It is classified as suppurative osteomyelitis and non-suppurative osteomyelitis. Suppurative osteomyelitis is nothing but the presence of pus infection, and non-suppurative osteomyelitis refers to the osteomyelitis which is devoid of the pus formation. Suppurative osteomyelitis is classified into acute suppurative osteomyelitis, chronic suppurative osteomyelitis, and infantile osteomyelitis. The chronic suppurative osteomyelitis is classified as primary with no acute phase preceding, and secondary which follows the acute phase. Non-suppurative osteomyelitis is further classified as diffuse sclerosing osteomyelitis, focal sclerosing osteomyelitis, proliferative periosteitis, otherwise known as Gary's osteomyelitis, and osteoradionecrosis. Now, suppurative osteomyelitis. The source of infection is usually an adjacent focus of infection associated with teeth or with local trauma. It is a polymicrobial infection. Polymicrobial is defined as which the infection which is caused due to a combination of different microbes. It may be bacterial, viral, or fungal, which predominates anaerobes such as bacteroids, porphyromonas, or prevotella. Staphylococci may be a cause when an open fracture is involved. Mandible is more prone than maxilla as vascular supply is readily compromised. Now in the panoramic radiograph, you can see the cropped panoramic radiograph of the suppurative osteomyelitis on the right side of the mandible. Now we see into the acute suppurative osteomyelitis the flow chart of the pathogenesis of the acute suppurative osteomyelitis. organisms, the microorganisms enters into the jaw, mostly the mandible, compromising the vascular supply, which is followed by the infection of the medulla through the marrow spaces. The thrombosis in the vessels leading to the extensive necrosis of the bone. Lacunae empty of osteocytes but filled with the pus proliferate in the dead tissue. Suppurative inflammation extends through the cortical bone to involve the periosteum. Stripping of the periosteum comprises blood supply to the cortical plate, predisposed to the further bone necrosis. Sequestrum is a dead bone formation, is found bathed in pus separated from surrounding vital bone. Now, if seen into the clinical features, early, late, and final. In early stage, it is characterized by severe, throbbing, deep-seated pain, swelling due to the inflammatory edema. Gingiva appears red, swollen, and tender. Late stage is characterized by the distension of the periosteum with pus. Final stage is characterized by the subperiosteal bone formation cause swelling to become firm. Now, acute suppurative osteomyelitis, when you look at the radiographic features or röntgenographic features, is defined as may be normal in early stages of disease, do not appear until after at least 10 days. Radiograph may demonstrate an ill-defined radiolucency. After sufficient bone resorption, irregular moth-eaten areas of radiolucency may appear. Now we see into the management of the acute suppurative osteomyelitis. Bacterial sampling and culture, empirical antibiotic treatment, drainage, analgesics, specific antibiotics based on the culture and sensitivity, debridement, remove source of infection if it is possible. Adjunctive treatment, sequestrectomy, that is removal of the sequestrum of the dead bone, decortication if necessary, hyperbaric oxygen, which will be explained later, resection and reconstruction for the extensive bone destruction. Chronic suppurative osteomyelitis. Now we look into the chronic suppurative osteomyelitis. Chronic suppurative osteomyelitis. Chronic is a term is defined as when the disease, the stimulus of the disease such that it progresses directly to the chronic stage, or if the acute stage of the disease is left undisturbed, is left untreated for a long period of time, it progresses to chronic suppurative osteomyelitis. So, as mentioned earlier, inadequate treatment of the acute osteomyelitis, periodontal diseases, pulpal infections, extraction wounds, infected fractures. Infection in the medullary spaces spread from and form the granulation tissue. The granulation tissue forms dense scar to the wall of the infected area. Encircled dead space acts as a reservoir for bacteria, and antibiotics have great difficulty reaching the site. Now we see in the clinical features characteristics of swelling, pain, sinus formation, purulent discharge, sequestrum formation, tooth loss, pathological fracture. Now we look into the röntgenographic features of the chronic suppurative osteomyelitis. Patchy, ragged, and ill-defined radiolucency. Often contains radiopaque sequestrum. Sequestra lying close to the peripheral sclerosis and lower border as seen in the radiograph. New bone formation is evident from below lower border as you can see in the radiograph. Next we go into the focal sclerosing osteomyelitis, which is otherwise called as a condensing osteitis. Localized area of the bone sclerosis, bony reaction to low-grade periapical infection or unusually strong host defense response. Association with an area of inflammation is critical. Now we see into the clinical features, children and young adults are mostly affected. In mandible, premolar and molar region are affected. Bone sclerosis is associated with non-vital or pulpitic tooth. No expansion of jaw is seen. When you look at the histologic features, dense sclerotic bone is present, scanty connective tissue is present, and inflammatory cells is present. Now we look at the focal sclerosing osteomyelitis of the röntgenographic features. Localized but uniform increased radial density related to the tooth, widened periodontal ligament space, or periapical area. Sometimes an adjacent radiolucent inflammatory lesion may be present. In the radiograph, we can see increased area of radiodensity surrounding apices of the non-vital mandibular first molar. Focal sclerosing osteomyelitis. When we look at the management, elimination of the source of the inflammation by extraction or by endodontic treatment. If lesion persists and periodontal membrane remains wide, re-evaluation of the endodontic therapy is considered. After resolution of the lesion, inflammatory focus is termed as a bone scar. Now we look at the diffuse sclerosing osteomyelitis. It is a ill-defined, highly controversial evolving area of the dental medicine. Exact etiology is unknown. Chronic intraosseous bacterial infection creates a smoldering mass of chronically inflamed granulation tissue. Now we look at the clinical features. It arises exclusively in adulthood with no sex predominance, primarily occurs in mandible, no pain and no swelling. Histology, bone sclerosis and remodeling, scanty marrow spaces, necrotic bone separates from vital bone and becomes surrounded by granulation tissue. Secondary bacterial colonization often is visible. Diffuse sclerosing osteomyelitis, when you look at the röntgenographic features, it is characterized by the presence of increased radiodensity surrounding the areas of the lesion. In the radiograph, you can see a diffuse area of increased radiodensity of the right side of the mandible. When you look at the management, elimination of the originating source of the inflammation with extraction and endodontic treatment. Sclerotic area remain radiographically. Now we look at the proliferative periostitis, also known as periostitis ossificans or Gary's osteomyelitis. It represents a periosteal reaction to the presence of inflammation. Affected periosteum forms several rows of reactive vital bone that parallel each other and expand surface of altered bone. Pathogenesis. The spread of low-grade chronic apical inflammation through cortical bone. Periosteal reaction occurs. Stimulates proliferative reaction of periosteum. So now we look into the clinical features of proliferative periostitis. Affected patients are primarily children and young adults. Increased incidence is in the mean age of 13 years. No sex predominance is noted. Most cases arise in the premolar and molar areas of mandible. Hyperplasia is located most commonly along lower border of mandible. Most cases are unifocal. Multi-quadrant may be affected. When we look at the röntgenographic features of proliferative periostitis, radio-opaque laminations of bone regularly parallel to each other and underlying cortical surface. Laminations may vary from 1 to 12 in number. Radiolucent separations often are present between new bone and original cortex. The proliferative periostitis, the histologic features, parallel rows of highly cellular and reactive woven bone. Trabeculae are frequently oriented perpendicular to the surface. Trabecula sometimes form an interconnecting meshwork of bone. Between trabeculae, uninflamed fibrous tissue is evident. With this, the next volume, I would take to the osteoradionecrosis and osteoemyelitis necrosis in detail. Thank you.